the next point. And the first speaker, it's an honor and a pleasure to introduce Professor Alain Combs from La Pitié-Salpétrière Hospital in Paris. So please, Professor, protecting and recovering the lungs.
Hello, I'm Professor Alain Combs, and it's a real pleasure for me to be here today to discuss with you VV-ECMO indications and results in patients with the ARDS. This is first my disclosure slide. So first, what is the rationale to use VV-ECMO in ARDS patients? We have actually a population of patients who are at immediate risk of death of either refractory hypoxemia, or for whom mechanical ventilation becomes very dangerous because of very low lung compliance. We have seen these patients during COVID-19 pandemic. They may represent up to 5 to 10% of the patients who have the most severe forms of ARDS, but ECMO would be used preferably to decrease the intensity of mechanical ventilation in most of the patients who have severe ARDS. And this is to minimize lung stress and strain, to decrease ventilator-induced lung injury by decreasing the tidal volume, the pressures, the plateau pressure, the respiratory rate, and the driving pressure, all together decreasing volutrauma, barotrauma, telectrauma, and biotrauma, the production of pro-inflammatory cytokines within the lungs, which may spill over into the blood and have deleterious effects on vital organs, such as the kidney, for example. We have very important data gathered over the last 10 years, and it appears that maybe the driving pressure, which is the plateau pressure minus the PEEP, will actually be the most important predictor of mortality in these ARDS patients. And there is an exponential increase in mortality when this driving pressure goes above 15, but there is no safe threshold for this driving pressure in that meta-analysis of many ARDS studies, and also evaluating all predictors of mortality in these patients. Very importantly, the respiratory rate also has been recognized as one of the most important factors in predicting the outcome of ARDS patients. In that sub-study of the LungSafe database, it was shown that there was an additional risk of death of 3% by additional breaths per minute of mechanical ventilation. This may be above a threshold, let's say 25, maybe 28, maybe 30, but for sure, using very high respiratory rate might be deleterious also in some patients. And the latest is the concept of mechanical power, which is the whole energy transferred to the lungs and the alveoli by the vent. This mechanical power is a component made of tidal volume, driving pressure, the flow, the PEEP, and the respiratory rate. But it appears that it's probably the respiratory rate and the driving pressure which have the most important factor, predictive factor in this formula. And it's been shown that there's also a threshold, probably around 18 joules per minute of mechanical power, above which also mortality increases significantly. And those are data from the LungSafe and Lifeguard cohort of patients. This is a prospective cohort of 350 patients on VV-ECMO we did a couple of years ago. And as you can see, the mechanical power drops down from very high level above 20 to less than 10 within minutes after VV-ECMO initiation, just by decreasing the intensity of mechanical ventilation, decreasing the tidal, the driving pressure, the plateau pressure, and the respiratory all together. So now we have some questions. When should we go for VV-ECMO? Which patients where? The first question is when. And actually, if the idea is to decrease the intensity of mechanical ventilation, VV-ECMO should be set as soon as possible. We have data suggesting that the mortality increases by 7% per additional day of mechanical ventilation awaiting ECMO. Those are data coming from a study we did in France a couple of years ago. In that series of patients, those patients who got mechanical ventilation, intubation, and ECMO in the 3 days following intubation had the best outcome. And on the contrary, those who got ECMO more than 10 days after being intubated had a very high mortality, close to 60%. And in that study, we also observed a major decrease in the driving pressure, the tidal volume, the plateau pressure, and altogether the mechanical power in these patients on VV-ECMO. Those are back to the lifeguard cohort also, the impact of VV-ECMO on the driving pressure, which was again highly different in the minutes, and decreased in the minutes following the setting initiation of VV-ECMO.